Welcome to the Theological Lens, where our goal is to see the world, our daily walks, and our worship transformed by the truth of Jesus Christ. Our content is saturated with Scripture, overflowing with faith, and rooted in the good news of the cross. Each episode will proclaim the name of the Lord, calling us to submit to His ways and live lives that glorify Him. With hearts full of thankfulness, we'll explore how Jesus shapes everything, our decisions, our worldview, and our worship, always pointing back to the hope and transformation found in Him.
Hello, everyone, and welcome to the Theological Lens. My name is Dr. Linnell Buchanan. I am so glad that you've joined me today because I am so excited about the topic that I want to make sure that you are aware of today. Earlier this week, I read some headlines that were amazing to me, like they were shocking and actually exciting to me. And it made me miss my residential classroom so much because these would have been great topics of conversation in those classes. Because there are two main headlines. I want to make sure you caught these because I think they indicate a seismic shift in the way that adolescent and childhood gender dysphoria is treated. Because what happened on January 30th is that a verdict was announced for a lawsuit, a medical malpractice lawsuit by a detransitioner. A young woman by the name of Varian sued her psychologist and her surgeon for medical malpractice. She alleges that when, as a minor, she was experiencing gender dysphoria, they did a radical mastectomy on her, removing her breasts. And then as she matured, she realized that there were other alternatives and she really regretted that decision. So her lawsuit was based on the following allegations. She said that there was not a thorough enough psychological evaluation as part of this process. And we do know that there have been therapists who have been advertising that with a 20-minute phone call, they'll get you the letter that you need for gender affirming care. So there has definitely been some sloppiness in the world of mental health workers on this issue, but she alleged that the psychologist did not do a thorough enough evaluation. She alleged that there was no exploration of alternative treatments for her that might not have included a body maiming surgery. And then she alleged that there was not proper informed consent because neither her or her parents understood the long-term consequences of such a radical procedure. So this young woman was awarded by a jury $2 million in damages. It is the first successful malpractice lawsuit by a detransitional. It's the first verdict that I know of in the United States. So I do believe that this is going to be the first of many, many lawsuits on gender affirming care. And I think they're deserved. And I think they will target a wide variety of practitioners. I absolutely believe that detransitioners will sue doctors who prescribe cross-sex hormones and who do these body-altering, body-destroying kinds of surgeries. And I also believe that there will be lawsuits against mental health practitioners who rubber stamped these, affirm first, ask questions later. And then I do believe that medical associations will be sued as well because the medical associations have approved and supported these procedures and processes. So that brings me to the next headline that shocked me, but also got me pretty excited because, and I'm maybe a little cynical because it's only slightly suspicious that this headline comes just a couple days after the first successful malpractice lawsuit by a detransitioner. Because a few days after the verdict dropped, the American Society of Plastic Surgeons published a new position paper, actually going against its previous positions on this topic. And here's what they said, and I'm going to quote it for you. The ASPS concludes that there is insufficient evidence demonstrating a favorable risk-benefit ratio for the pathway of gender-related endocrine and surgical interventions in children and adolescents. ASPS recommends that surgeons delay gender-related breast/chest or genital or facial surgeries until a patient is at least 19 years old, unquote. Please note that this is not a binding clinical guideline, but it is a recommendation. I guess that's improvement in some direction. And this is just my opinion, but I read this as more about covering their heinies than any like indicated moral growth. So the very next day, surprise, surprise, the American Medical Association issued a statement suggesting that they might agree with the ASPS that surgical interventions for gender dysphoria should be deferred until the age of 19. I really don't mean to be cynical or anything else, but all of this timing seems highly suspicious to me. And I want to spend some time today and catch you up on how we got to this moment and why it is so important that we do better by children and adolescents. So, first, let's start with a little bit of history because gender affirming care isn't an altogether new invention. Its roots go back into the mid 1900s, and that's farther than you might think. But this focus on minors as candidates for this stuff, this is a relatively recent development. So the concept of realigning one's body, one's reality, physical reality, to align with a perceived gender identity through some sort of medical means actually emerged in the mid 20th century. In the 1950s, 1960s, endocrinologist Dr. Harry Benjamin in the US formalized some guidelines for hormone therapy and also surgery for transgender adults. His work led to the first gender clinics, like the one at Johns Hopkins, that was established as this first gender therapy clinic in 1966. So it pioneered these gender affirming surgeries, which were back then called sex reassignment procedures for transgender adults. That was their only target, was for adults. It was a groundbreaking program, and it involved multidisciplinary teams that included surgeons and psychiatrists and endocrinologists like John Money and John Hoops. Now, if hearing the name John Money doesn't turn your stomach a little bit, then you need to learn some more about this terrible man. John Money was a New Zealand-born American psychologist who played a pioneering role in sexology. He's the one who is credited for coining terms like gender role or gender identity in the 1950s. And he helped shift discussions from purely biological sex to this social and psychological aspect of gender and this self-perception, how an individual might consider their own gender, which he viewed as absolutely malleable through upbringing, the nurture side of things instead of the nature, the genetic side of things. So Money remains one of the most controversial figures in the whole history of the psychology and sex research, but there's a lot of people who do not realize how despicable some of his work actually was. So his controversies focus on a few key areas, and the one that just cannot be missed is the David Reimer case that's sometimes referred to as the John Joan case in Money's published work. This is by far the most infamous and damaging controversy. In 1965, a Canadian twin boy whose original name was Bruce, he became known as David later, suffered a botched circumcision at 8 months old. And that resulted in the loss of his penis. So his parents consulted with John Money, and he recommended that they should raise David as a girl and just create a surgical construction of female parts based on the theory that his gender identity would primarily be shaped by socialization in the first 2 to 3 years of life. They believed how his parents treated him, whether as a girl or a boy, would be what dictated whether or not he perceived himself as a girl or a boy. So Money ended up presenting this case, which, he anonymized as the John Joan case, as a success in multiple publications. Like, it was a big win, claiming it absolutely proved that gender was neutral at birth and it was really just socially constructed. And then also it supported the idea of early sex reassignment for children. He skipped a whole lot of stuff because in reality, David never identified as female. He experienced severe distress, including gender dysphoria, bullying, suicidal thoughts when he was pushed to present himself as a female. He rejected the female role in adolescence, transitioned back to living as a male. Around age 14 to 15, he underwent surgeries to reconstruct male genitalia, and then he later married. But his life was very troubled. He did commit suicide in 2004 at the age of 38. So if I were to explain that I believe that John Money was a bit of a scumbag, I'm going to let me count the ways. Here's my list. He misrepresented this case's outcome for years. And that led to a widespread belief that this kind of thing would work perfectly, even though the one time it was tried, it did not. So he claimed success despite very clear evidence to the contrary. Number two, there were severe ethical lapses involved here. The family was never fully informed of the risks of how this would potentially affect David and the rest of the family. David was used as an unwitting experiment just to test Money's theories. That's not right. Number three, there are some really awful allegations that David made about what follow-up visits with John Money looked like. He said that at the age of 6, Money forced he and his twin into simulated sexual behaviors and very invasive inspections that David reported were very traumatic, very coercive. And of course, Money denied all impropriety involved in that. And I have not even gotten to Money's views of incest and pedophilia, because those are concerning as well. He described pedophilia as a condition rather than a crime. And in some writings, he distinguished between, the non-violent pedophilia, which should be separated from the violent pedophilia. Okay. And then he appears to endorse and downplay incest and its negative effects, or downplay adult-child sexual contact as not necessarily harmful in interviews and writings. So these positions drew very deserved accusations of moral relativism, of permissiveness towards abuse. It was really, really yucky. But and his legacy is dominated by these ethical and moral failures, but he still had this really, really deep impact on this broader discussion. We should look at Money's activities as a cautionary tale, because it's about unchecked experimentation on children to support adult theories. It's about questionable informed consent, and it's about the risk of prioritizing this theory over patient well-being. You would have thought that we should have learned from this. I mean, after all, Money stuff was happening in the late 1900s, and we are now decades later. But here we are, all these decades later. And this whole discussion of gender dysphoria in children is riddled with questions of, wait for it, the same problems. Unchecked experimentation with children and adolescents, informed consent problems, and the risks of prioritizing theory or ideology over the well-being of children and adolescents that should get much more care than all of that. So back to our timeline. Money influenced the formation of these gender clinics, like Johns Hopkins. And Johns Hopkins actually performed surgeries, these sex reassignment surgeries, for about 13 years until they abruptly closed the gender clinic there in 1979. And the official reason was based on emerging evidence suggesting that surgeries did not produce long-lasting benefits, that often the people who had had some sort of sex reassignment surgery relapsed into a dysphoria. They needed another surgery. And then they relapsed into dysphoria. They needed another surgery. And there wasn't long-term improvement that they were seeing. Specifically, a 1979 study by psychiatrists Meyer and Reeder, this was published in the Archives of General Psychiatry, followed up on patients who had undergone some sort of surgery versus those who were denied for the surgery. So both groups came to the clinic asking for sex reassignment surgeries. Some were denied, some were given the surgery. They looked at a comparison of the outcomes of those two groups. And it was concluded that the post-surgical patients showed no significant improvement in comparison to the non-surgical group. And many remained very troubled, even if they were satisfied with the procedure itself. They still were struggling. So Paul McHugh, who was in charge of the clinic at the time, cited all of this to argue that the hospital was fundamentally cooperating with a mental illness by offering these surgeries, and that he then shut down the program shortly after the study's closure. So this Meyer study influenced not just Johns Hopkins, but contributed to the closure of or scaling back of several different programs at other U.S. institutions in the late 70s and early 80s. Now, when it comes to minors, the story shifts to the late 1980s and 1990s in the Netherlands. That's where the Dutch protocol was originated. That is a staged approach to adolescents or children that have gender dysphoria. And it starts with puberty blockers around age 12. And that's supposed to pause puberty that will then give the child time to come to a conclusion about whether or not they really want to transition or not transition. And then if dysphoria persisted, then cross-sex hormones would be started around age 16. And surgeries then would start after 18. So the first key study on this came out in 1998 from some Dutch researchers, and I'm not even going to try to read their names because they're Dutch. They reported this big report in 1998 was on a single study following this Dutch protocol where a teen used blockers and then later transitioned, and it showed improved well-being. So, well, after all, based on that one case, we should go forward. So that also laid the groundwork for some additional studies. In 2011, a Dutch team published results from 70 adolescents that were treated with blockers. And they found that the gender dysphoria decreased after the usage of the blockers, and that psychological functioning did improve post-treatment. However, despite the fact that there were people who called these the gold standard in research, others pointed out that there was very weak science behind these studies. The first study, one patient and not with long-term follow-up. So, and the other study, samples were small, early onset cases, that kids that have dysphoria from early childhood are different than other kinds of cases where it's developing later. There weren't long-term controls. There wasn't long-term assessment. And then they noted that not all the kids qualified for this. So the Dutch were very, very picky about who they would put through this protocol. And then this was being generalized to situations where doctors were not being picky. They were just anybody who wanted it. Let's do it. And so there was a lot of criticism that emerged about this research, and yet everybody started relying upon these two studies. So the Dutch protocol spread to the United States, spread throughout Europe in the early 2000s, and it got endorsements from groups like the Endocrine Society and the World Professional Association for Transgender Health, also referred to as WPATH, in their standards of care. So by the 2010s, referrals to gender clinics exploded. They were up 4,000% in many cases and more, often involving teens with later onset dysphoria and also co-occurring mental health disorders like autism or trauma. So this massive explosion in the early 2010s really changed so much about how people thought about transgenderism as a whole. Pre-2010s, transgender identification and clinical referrals were relatively stable and low. There were very few people who identified that way, and those numbers had stayed the same across a great deal of time. And they were primarily biological males who found sexual excitement from thinking of themselves as female and dressing in feminine kinds of ways. And this is referred to as autogynephilia, which is an attraction to oneself. Historical estimates placed transgender prevalence at around 0.1% to up to 0.5% in adults globally. And referrals to youth gender services were very, very, very rare pre-2010s. But in this early 2010 and onward, with a major inflection point around 2013 to 2015, referrals rose sharply in westernized countries, only westernized ones. That's weird. This just accelerated dramatically from around the 2014 to 15 range. Exponential growth was reported from multiple kinds of sources. In the UK, referrals to the Tavistock Gender Identity Disorder Clinic increased starting in 2014, rising from normally in a year, they would get in the low 100, 200, maybe 300 range of referrals. And all of a sudden, they were getting thousands of referrals by the late 2010s. Where did all of those come from? The majority shifted to adolescent females instead of the adult males who wanted to sexualize themselves. It was all of a sudden adolescent females who were uncomfortable with their developing bodies and were kind of rejecting some of that development. In the Netherlands, which was the birthplace of this Dutch protocol in the first place, referrals surged around 2012 and 2013. And again, it was late presenting adolescent females. And then similar patterns emerged in Canada, Sweden, Finland, Australia, and in the US. And clinic data demonstrated increases of somewhere between 10 to 40 times what they had previously gotten in referrals over the next decade. So the mid 2010s to the early 2020s was the time of this peak surge in adolescents and children who were identifying as transgender. And this was primarily self-reported identification. In the US, both Gallup information and also CDC data show transgender identification among 18 to 24-year-olds increased by 5-fold in those years. Youth aged 13 to 17 estimates reached over 724,000 individuals just in the US in that time. Broader non-cisgender or non-binary identification emerged among college-age individuals, and that hit highs of 4 to 8% of those who went to college identified as either non-binary or non-cisgender, which with females, by the way, outnumbering males in that identification as non-binary. Globally, estimates suggest that 1 to 2% of adults identify as transgender or non-binary in some surveys, but youth rates in westernized countries are way higher. Some recent trends in the last 2 years, some data suggest that there is a potential plateau that we might have reached on this one, or even a slight decline in self-identification among young people. And we are seeing rising numbers of detransitioners. That is, people who at one point identified as transgendered, but no longer do. And this is often happening in late adolescence and early young adulthood. So all of these numbers raised some questions. Was the evidence from those early Dutch studies robust enough for this brand new wave of patients that didn't look like previous patients looked? Remember, these were usually adult males, and it was based on autogynephilia. It was based on a little bit of fetish kind of behavior. And now all of a sudden we have young girls that were never part of the transgender population coming in large numbers, even sometimes in whole subsets of peer groups. Studies in the 2010s, 2020s linked gender affirming care to lower depression and lower anxiety in trans youth, and they promised better mental health outcomes. The narrative actually became a little bit threatening, because if your gender dysphoric child did not transition and parents weren't appropriately supportive and affirming of that transition, then they were told their child would commit suicide. And And so parents of these adolescent girls who were clearly struggling with some other psychological issues and struggling to accept their bodies as they grew and changed and developed, they were told, well, would you rather have a live son or a dead daughter? As if those are the only two options. So you just have to pick, either affirm and you'll have a live son, or you don't affirm and you'll have a dead daughter. That's your only two options. I'm not sure that counts as informed consent. So systematic research started highlighting some pretty significant gaps. Many of the studies that had been created were observational, they were short term, and they did not isolate the effects of care from other factors like family support. So, in short, the history of this transgender research shows a field that is based on innovative but very limited research, starting with adults and then extending to minors as if they're the same things. It's a story of progress amid uncertainty, which essentially meant that the whole field was learning as they went and experimenting on vulnerable children and adolescents. So that brings us to a pivotal moment that has occurred in the last 4 years, and that is the Cass report. The Cass report, which was officially titled The Independent Review of Gender Identity Services for Children and Young People, was commissioned by the NHS in England in 2020 because they were seeing soaring referral rates to this gender identity clinic at Tavistock. And they had real concerns about the quality of the evidence that was out there about protocols and processes. So it was led by Dr. Hilary Cass, who was a retired pediatrician and was a former president of the Royal College of Pediatrics and Child Health. And obviously, he had quite the credentials there for this study. An interim report was published in 2022, which got out some early data, but the final report didn't come out till 2024. But the early data from the interim report was cautionary enough that it really rocked this whole discussion of gender identity treatment and actually created an impetus for the closure of the Tavistock Clinic, which gradually closed from 2022 to 2024 and now no longer exists. So the Cass team reviewed over 100 studies. They interviewed patients, they interviewed families, they interviewed clinicians, and they also commissioned systematic evidence reviews that included the University of York. And what they found was that the evidence base for gender affirming care in minors is, and I'm going to quote, remarkably weak, unquote. They concluded that the rationale for early puberty suppression is unclear, with limited proof of benefits and potentials for some significant risks, including bone health, fertility loss, brain development damage. Their key points from this report said, gender dysphoria in kids is often co-occurring with other mental health issues. And the report suggested a holistic approach instead of immediate medicalization. Therapy first. We don't just rush to block puberty and give cross-sex hormones. And it noted the, and I quote, exponential increase, unquote, in referrals, especially among teen girls, questioning if there aren't some social factors that are playing a part in this dramatic rise. Now, the report made 32 different recommendations. I'm not going to go through all of them, but I want to highlight a couple of them. One of those recommendations was that they ban puberty blockers outside of clinical trials for anyone under the age of 18 because the cost is just too great. And the UK did implement that recommendation. They suggested that they create regional hubs for comprehensive care for those who have gender identity issues, including deep, rich psychological care, and that research be prioritized instead of assumed. So the National Health Services of England responded by they committed to those reforms, and they even extended the scrutiny to some of the adult clinics that were serving the young adults, the 17 to 25-year-olds, who, also may need some protection in this process as well. In the United States, a 2025 HHS report echoed the findings of the Cass report, and it called the evidence of the benefits of gender-affirming care wildly overstated. The Cass report and the U.S. report didn't ban gender-affirming care outright, but they did call for caution and for better data. And it has fueled some global shifts, including some bans in places like Finland and Sweden, where policies now absolutely do limit interventions to only in research settings. And this ties directly to how medical associations are suddenly responding this week. And I really do think they're responding out of nervousness, and they have a right to be nervous. Medical associations have long shaped the standards of care. Historically, groups like the Endocrine Society, who came out with guidelines in 2009, and the American Association of Pediatrics, whose 2018 policy endorsed this Dutch protocol, this approach that was inspired by research on one person. And they emphasized multidisciplinary care and affirmed that blockers and hormones can be life-saving for some minors. And some medical associations just automatically deferred to the WPATH, that is the World Professional Association for Transgender Health, their standards of care, which have been most recently updated in 2022. Now, WPATH has its own scandalous debacle that emerged in even more so in 2024. The organization has clearly chosen money and prestige over its for money and prestige for its members over the children and adolescents that it serves. They have willingly sacrificed the bodies of hurting individuals on the altar of ideology. And WPATH deserves its own videos. Maybe someday I'll do that one. If you want to see it, drop a comment below and maybe I'll get to work on that one. So now, as of this last week, we have two medical associations who are breaking form with the rest. They are breaking away from the affirm and maim model of treatment. I cited them at the beginning, but I'm going to remind you, the American Society of Plastic Surgeons, that's the largest group for that specialty, issued a position statement recommending all gender-affirming surgeries be delayed until the age of 19. That includes breasts and genitals and facial surgeries as well. So they cited low-quality evidence, potential harms, ethical concerns about irreversible procedures in minors. And this did break from their prior endorsements of those kinds of procedures. And then, following in their footsteps, the AMA strengthened, and the AMA had strengthened their support for gender-affirming care in 2023. So they've been on a trajectory, giving it more and more affirmation, and all of a sudden they went, oh, maybe it's not a good idea, right after a successful malpractice lawsuit. I'm shocked. So now they say, in the absence of clear evidence, the AMA agrees with the ASPS that surgical interventions on minors should generally be deferred to adulthood. Again, the AMA still backs evidence-based care overall, including non-surgical options, including puberty blockers and cross-sex hormones that have tremendous negative impacts on people. They still back that stuff, and they still absolutely oppose criminalizing any gender-affirming care. So not all the groups have shifted. Maybe we'll see more in the coming days, but the American Academy of Pediatrics reaffirmed its 2018 stance in 2023. So they are still in that affirmation mindset. The Endocrine Society maintains support for both puberty blockers and cross-sex hormones. But at least the move of the plastic surgeons and the AMA signal, hopefully, a growing caution, especially on surgeries. So these positions actually reflect some broader ethical tensions, the balancing of autonomy and potential risks, and potential benefits in a field that doesn't have strong evidence. And these associations have also influenced laws. 27 U.S. states restrict care in some way for minors, often citing some similar kinds of concerns. So if these of the broader groups of medical associations would all get on board, I think that number would grow, and we would see more states saying, maybe we shouldn't be doing this stuff to kids. I would be all for that. So now back to that detransitioner lawsuit. So her key complaint that she made were that her psychologist, Kenneth Einhorn, and her plastic surgeon, Simon Chin, failed to obtain informed consent. They didn't adequately assess her, and they rushed the procedure without exploring alternatives. So Varian argued that her dysphoria stemmed from other untreated mental health issues, and that she later regretted the surgery. Now, informed consent is truly problematic when it comes to gender dysphoria in children, because informed consent requires the following. It says you have to be able to explain clearly to your patient or your patient's representative, in the case of children, to the parents, what the nature and purpose of the intervention is. You have to explain what the potential benefits, in this case, it might be reduced gender dysphoria or improved mental health in some cases, maybe. But you also have to explain known risks and side effects. And this is where so many detransitioners have said that their medical teams fell down on the job. They did not explain things like the impacts on bone density from puberty blockers and cross-sex hormones, or the damaging of fertility that can come from that. The negative impact on brain development that's irreversible in these just hormonal treatments. Also, sexual dysfunction. Did you know that puberty blockers and cross-sex hormones have been known to cause a change in the potential for orgasm, where these kids who have undergone this treatment will never be able to orgasm in their whole life? How can you say that you have explained that risk fully to a child, that a child agrees to that risk? The child doesn't even understand what that means. And then also risks to cardiovascular health. So there's a whole bunch of risks that would need to be explained very clearly. And we have not even gotten to how many of these surgeries have tremendous complications that require more and more and more surgeries to try to correct. That's a whole other video entirely, and it would probably be like rated R or greater, because it's just some really, really yucky things. And then they also are supposed to, in informed consent, convey the truth about uncertainties that they have. So they should be talking about the fact that we don't have good long-term data, that there's weaknesses in the research. Do you think anybody was discussing that? No, they were just saying, oh, you want the surgery? Okay. You want the puberty blockers? Okay. And no consideration was made about really warning so many of these detransitioners about what they were signing up for. And certainly this informed consent is very complicated with minors for several different reasons. As a society, we long ago recognized that minors do not have the same capacity to grasp long-term risks. Adolescents' brains, especially the prefrontal cortex that governs impulse control, their risk assessment and their long-term planning, all of those are still developing into their mid-20s. And this limits their ability to fully grasp the irreversible consequences that they're signing up for. And there are certainly some pretty significant irreversible consequences, like that inability to experience orgasm, or infertility, or lifelong medicalization, where you're going to need constant medical care for the rest of your life. There is evidence that many children and adolescents were given incomplete or inaccurate information when it came to that. Like, for instance, there was the minimizing of risks when it came to puberty blockers. Over and over and over again, people said, oh, it's just putting a pause on puberty. It's just giving them time to explore their gender and become more certain. And then it's fully reversible. No, false. It's not fully reversible. But many did not have that warning. And then there was also the people who didn't explore treating the co-occurring mental health issues before they started providing these body maiming surgeries. Like maybe you should deal with those questions of autism or trauma or what have you first before we jump to these solutions. Whistleblowers and reviewers have noticed that there was rushed processes or affirmative models that prioritize identity affirmation over comprehensive evaluation and comprehensive exploration. And leaked documents in 2024 from that WPATH organization revealed internal discussions acknowledging that some youth could not fully understand the fertility or sexual impacts of their treatment. But don't worry, they pushed forward in that same model of care anyway, not caring about how that was damaging those young people. Parental consent has long been required for this since children and adolescents cannot, truly comprehend these risks. But conflicts arise if parents disagree or pressure exists. And we've seen many public stories about divorced parents' disagreement on appropriate treatment for a child that is labeled as transgender, or one parent is seeking some gender affirming care, and the other parent is saying, "Wait, we shouldn't do that." And this has hit the court systems. There's just some heartbreaking stories that you can find with a quick Google search. And then years ago, I watched a documentary called Transhood. I think it launched in 2020. And in this documentary, they followed, I think it was 4 transgender children and adolescents, and watched them in their life and interactions with their family. And as it followed them, I had significant concerns about whether or not the parents were healthy themselves. Because especially the moms, they seem to have their own motivations for their children's identification as transgender. And if you watched it, I would love to hear your perspective. Do you see the same red flags that I saw? If so, drop some comments below, because that's a dialogue I would love to have. So legal experts say that the news that we got this week, this first judgment and the moves by these medical associations to say maybe we shouldn't do it until they're 19, they say that this is going to inspire more lawsuits. And in fact, there are at least 27 lawsuits that are currently pending, although most of them will probably settle out of court and not hit the headlines very well. Detransitioners like Varian represent for sure a growing group. I think we're going to see more and more and more of these lawsuits. And what it underscores are some significant ethical questions. So how thorough should the assessment be? Because it ought to be more than the 20-minute phone calls that therapists were promising to get their approval letters. Like, that's ridiculous. And then what counts as informed consent for minors? What role should we allow parents to have when there is so much risk for these procedures that the children and adolescents cannot properly understand? Varian's suit focused on her provider's alleged negligence, and it adds to this legal landscape where providers are going to face rising malpractice risks, and states are going to have to grapple with these bans versus this question of what is appropriate access to care. So what this all means, this field of gender affirming care is shifting really, really rapidly right now, right this week. From the Dutch protocol in the 1990s to the Cass report that dropped fully in 2024, there is a wake-up call about weak evidence, and then to these medical associations updates. This suit about accountability, it really is clear that we are in a different moment than we were in 5 years ago. There's an era of reevaluation, and I think it is so long overdue. The needs of vulnerable children and adolescents demand nothing less than an urgent reconsideration of these processes. We got to stop harming the little ones. We should go back to a posture of protection for these little ones. So that's my soapbox issue for today. And I would love to hear your perspectives in the comments below. Thank you for joining me today. I look forward to seeing you next time on The Theological Lens. And in the meantime, grace and peace to you.
If you enjoyed what you just heard, we invite you to like the episode and, if possible, leave a positive review. If you know someone who could benefit from this content, please share it on your social media. We also ask that you subscribe and follow so that you don't miss any of our upcoming episodes. We are so glad that you chose to be with us today. We hope that you will join us again next week on The Theological Lens.